Good afternoon, everybody. Thank you very much for joining us today. This afternoon, we'll be going over getting started with MIPS in 2023 and what you can do to improve your score. There is a lot to go into this. A lot of it you may have seen parts of before. I tried to add a little more of the tricks of the trade and tips of things that I have done and helped with our clients in the past. So if you've seen my webinars before, it'd be a very similar process, but some new items added to it. First off, my name is Mike Lewis. I'm a MIPS specialist here at HealthMonics. I will be guiding you through this presentation alone today. So if I don't get to your questions at the end, I definitely will be following up with you at the latest by tomorrow with answers or direction of where to go with any of your MIPS questions that you have. So a little background for the webinar that we have here. We use the GoToWebinar widget. Gives you the ability to both ask questions to me here through chat, as well as provide you with some handouts. The handouts include the latest slide deck, and I'll also be sending everything after the webinar through the slide. I'll include the slide deck, the video of this webinar, as well as ways to get a hold of me directly. So if you have any questions or concerns, feel free to ask on our app. All right, so what are we going to review today? Measure selection, so 2023 strategies on measure selection. I think we're still early enough in the year that we can make some changes, but it's really important to know that 2023 is difficult and scoring well on these measures have become hard, but you still also want to take this time to track and learn what you need to do for following years as well. So it's a good idea for you to not only choose measures for 2023, but understand that your strategy for 2024 and beyond can be helped out a whole lot by choosing the right measures. We'll go over some tips. So tips to improve your overall performance. Every practice that I've worked with is different. Every provider, every MA, PA, nurse practitioner that I work with has a different workflow, has a different idea. So we'll provide you some tips as well as some abilities for workflows and process improvement to reduce the burden. This shouldn't be a terribly long webinar. However, working by myself, I probably won't get to all of the questions throughout the time, but I will follow up as I stated. So why is MIPS important? We'll start off with this. A lot of us talk about MIPS as a have to do, kind of like your taxes, but there are some really strong reasons of why MIPS is important, and I share a couple of them here. It focuses on your quality improvement. While you may think, and I've always mentioned before, it's your click quality. It's not the actual quality that you're using in the program with your patients. Getting you in that rhythm of answering this has actually improved quality of care. Focuses on improving patient outcomes, so it's trying to get you to answer the right questions to improve their outcomes. I think in the beginning, when there was a lot of measures like your smoking and pneumonia and flu and things like that, that everybody was answering, it may have helped the patient by informing them that these are things that they need to do, but you're mostly doing that. The outcome-based measures that are now coming out are more aligned with where CMS wants to be, understanding a patient goes from A to B, how did they get there, and what was the outcome of it. Incentivizes the adoption of EHR technology. That's a big one, as the meaningful use days back in the day, as well as moving into promoting interoperability. The use of EHR technology, I think one of the big ones was e-prescribing has reduced errors in prescriptions drastically, and it's been a big impact. The future of EHR technology and being able to have pure and true interoperability between systems will help patients moving forward. It provides a framework for measuring and comparing to other clinicians. Helps patients make more informed decisions about their care, whether they're looking at online information of how you're doing with your quality measures, or it includes feedback and other frameworks of the technology, taking a look at websites, what is the portal that you're using? Do you offer things like that? Help clients make their decisions. Provides a stepping stone for ACOs. CMS has pushed people to ACOs over and over for the last couple of years, and by 2030, they want to eliminate the MIPS provider as traditional MIPS provider and moving more people towards either an ACO model or some other type of value-based agreement on top of what they've been doing. So they're looking to do that in the next 5 to 10 years. And the anticipation is that a lot of the things that you have been tasked with doing over the last couple of years are going to be part of what you're doing moving forward. Facilitates financial incentives to consider quality, performance improvement, and optimize cost. I think, they've been pushing the quality and performance improvement for year after year, continually make these scores harder to achieve, whether you're talking about individual measures or the overall score of your MIPS providers, and then optimizing the cost of care. We haven't hit that really hard yet. A number of providers in 2022 will see it for really the first time in impact their overall score, and then in 2023 it is here, and we'll be monitoring that pretty closely here at Health Monarchs. So what has changed and stayed the same in 2023? So what's changed? The exceptional performance bonus was eliminated. So that little bump at the end of, for those people that fit into the exceptional performance, whether it was in past years above 75 or above 85, and I think 90, that is gone starting in 2023. There are 9 new quality measures. So that's important, and I'll tell you why in a couple slides here. New quality measures have been added and will continue to be added at a much higher rate than in the past. And then there are 11 quality measures that were removed, including a couple that you should be very familiar with and understand that they're not here in 2023. So the big thing, obviously, is the exceptional performance last year was in 2022. And now there is a straight line incentive program from the 75 points, or from 100 points all the way down to 0. So I'll show you that too as well. What stayed the same? Providers need to reach 75 points to avoid the MIPS penalty, which starts at 9% when you're at 0 and climbs up to 75 points where you'll have no incentive and no penalty. They will continue to reweight PI for small practices. Providers need to report on 70% of their eligible encounters for all quality measures. Now, those who are reporting through their EHR, most likely reporting on 100%, but CMS is asking and pushing as many people as they can to report on 100%. And I do see language in the rules that percentage will move up over the next couple of years. Providers need to report on at least one outcome or high priority measure. That's still the same. There's a 20 case minimum per measure. And then the eligibility is exactly the same as it has been for the last number of years, 90,000 plus in Medicare Part B charges, as well as 200 Medicare Part B patients and 200 covered professional services. To be eligible for MIPS, you need to have all 3 of those categories. If you at least qualify under one, you can opt in. If you don't qualify for any as a group, at least, you are ineligible to report. As an individual, you're ineligible to report if you, as an individual, if you don't qualify for all 3, or at least one of those 3 categories. So I'll start off with small practices. And for you to know, I also had put out a small practice blog this past week. If you go to our website and you take a look in the top right-hand corner and click blog, you'll see the latest blog is on small practices and MIPS reporting. So for small practices, the Promoting Interoperability is automatically reweighted. That doesn't mean that you you're not going to do it, you can still do it and opt in, and then your graph will look more like what I'm going to show you on the next page. But the big thing here for small practices, and these are 15 or fewer providers, is that if you are PI exempt, or if you decide not to report PI and you don't have any cost measures, your score is 50% for IA and 50% for quality. So you really are ahead of the ball game with getting at least a 50% score, 50-point score, with, as I like to say, the freebie and improvement activities. If you do have a cost measure, and there are a lot of them, and many people on this call will have cost measures in 2023, your score will look like what you see on the left-hand side of this screen, where it is more or less evenly split, with quality having a 10% more score. For large groups here, what you see is the standard weighting. So this would be the same standard weighting for small groups if they decide to report PI. For large groups, you can see that cost and quality are equal to each other at 30%, IA still at 15%, and then PI at 25%. If you are PI exempt, so for large practices to be PI exempt, you are looking at groups that don't have, or that are all in hospital settings. There are some other categories that are also PI exempt. There also has been some changes this year. NPs and RNs are no longer exempt from PI, so you have the ability, or you have to report PI. But clinician types that haven't had to report PI in the past, most of them are still the same. And then if you are PI and cost exempt, as you can see, 85% of your overall score would be from quality, and IA stays 15%. So large practices are at a bit of a disadvantage compared to the small practices. Here's an example that I was sharing, I was talking about a little bit earlier. What you can see is this is more straight lined. In previous years, when you got above 85 points or 90 points, it curved straighter. The curve was more steep, So what you see here is at 100 points, it's 9%, all the way down to you get to 18 points where it's negative 9%, and it stays at negative 9% beyond that as well. Now, this is not saying this is what you're going to get for these scores. This is anticipated incentive due to this being a program that the people who pay the penalty pay for the people who receive the incentive. So if more people are in the lower part of this where they're paying a lot into the program, those who are doing well are going to get paid more at the top of the program. But this is a bit different than in previous years, as there is no steeper curve for those in the exceptional performance category. So here are some quality facts for small practices. So this is the 15 or fewer positions. Submission methods, you have the registry submission, which are your CQM reporting. You could do that here through HealthMonix. You have EHR submission, which you can do through HealthMonix as well. Those are your ECQMs, and you could also do those through your EHR, and a lot of our EHR partners that we have out there utilize us for that. And then there is the Medicare Part B claims, really getting to the point where it's not usable to do Medicare Part B claims. Their measures are extremely topped out, hard to get good scores on, and CMS is eliminating many of them as the years go on. That is not a method in which CMS wants to move forward with anything, and has gotten rid of it for large practices a couple years ago. And now in 2023, it's still available for small practices, but not very easily scored. So I highly recommend not reporting through Medicare Part B claims. Failure to meet data completeness, under 70% of the data completeness per measure will result in a maximum of 3 points for that measure. So that is a trick from about 5 years ago about reporting not all of your patients and just reporting a minimum to pass the quality part. That is 3 points is not going to do it for you on a measure now. So reporting 70% on each one of your measures is definitely where you need to be. There still is the bonus points, the 6 bonus points are automatically added to the quality category. I will tell you I did make a statement that they were gone in a previous webinar, but I was corrected and share with you that those points are still available for the small practices. Measures that don't meet the case minimum, so measures that don't meet the 20 case minimum will earn a maximum of 3 points. So you need to get at least 20 patients in the denominator of each measure for them to have the potential to receive maximum points. So you need to have at least 20 patients. You need to have over 70% of the 70% of your overall patient population for each measure to be counted for the measure to count. So you want to pick measures, and we'll get into that have lower denominators, but you need at least 70% of those eligible visits to count. Measures without a benchmark, so measures without a benchmark will earn a maximum of 3 points. That is, if they don't have a benchmark at the end of the year after CMS calculates everything. Measures that have enough providers that report, or enough clinicians that are reporting on them throughout the year will get benchmarked after the year is over. I've gone over benchmarks in previous webinars. If you have questions, I could get you some slides or point you in the right direction of what they look like and why you need to choose certain things when it comes to benchmarks, as well as I'll share some parts today. Measures with a benchmark will earn 1 to 10 points, as well as the highly topped out measures will only earn 1 to 7 points. So there's a 7-point max on those measures. So for your large practices, these are practices that have 16 plus clinicians that are billing Medicare. So you want to make sure you know whether you are a small practice or a large practice. You could reach out to me, or you could reach out most likely to CMS to make sure if you're kind of on that bubble there of what they're considering MPIs that are in your practice and whether you're small or large. The submission methods for large practices, there are only 2. There's registry submission as well as EHR submission. Both, once again, can be done here through our HealthMonix, through our MIPS Pro platform. Failure to meet the data completeness. So now for this is a little bit different from the small practices. Failure to meet data completeness, basically if you're under 70% of your completeness threshold for each measure, the maximum amount of points you can get is 0. So you won't get any points for that. There are no bonus point opportunities for large practices either. Measures that don't meet case minimum, so the case minimum of 20 patients per, or 20 cases per measure will earn you 0 points as well. And measures without a benchmark will earn you 0 points. So there's a lot of negatives to the large group, so you want to make sure that you are reporting enough of measures that have benchmarks, and then the same thing with your benchmarks for will earn you 1 to 10 points with things that are benchmarked, as well as highly topped out measures. Maximum you can get is 7 points. I know there's a lot to take in, but there are a lot of the ability to reach out to me afterwards, as well as some of the information that I have on the website and blogs that'll be coming out as we get out of busy season of the reporting time frame in the first quarter of the year. We will be putting out more webinars and blogs and posts and things like that that can help you navigate MIPS in 2023. All right, so a couple of the strategies for measure selection. As I stated, this is the main area that I'll go over today. So strategies for measure selection. Choose measures that align with your practice and patient population. So inside the MIPS Pro program, you can filter the measures in 10 different ways that you see on the left-hand side. This is in behind. Once you purchase a license with us, you have access to this information that you see over here. My favorite thing to do is actually click on the code section and type some of those CPT codes that you are using in your practice to see what measures you may be eligible for. We also have the ability to track them by the CMS measure sets. You can include or not include measures that are capped or topped out or benched or topped out benchmarks, as well as choosing your high priorities, your outcome measures in here. You can select all measures as another option within our program, where after uploading your initial data set, you'll be able to see what measures you're eligible for. And then you could see on the right-hand side, you could have the ability to select or view the details and see what the benchmarks are, what information is needed, how often do you need to report it on, what are the codes that are needed for you to maximize your score for this individual measure. But the other thing too, as I said, is that one thing that people are utilizing our system for is that they go in and instead of picking, 6 or 8 or 10 measures, they're picking 30 measures, uploading their first set of data into the system. And that way you can tell and see what patient populations are being loaded into different measures that you may not have been tracking before. That can give you the opportunity of, oh, that makes sense to me, maybe I can add that, or maybe if I change what's in my EHR, I can track it for next year. Or as a CQM and being able to work through a registry, is that data somewhere else within your EHR that you can go get that information and say, yes, I did XYZ, and upload numerator information so that you can get credit for those measures. This is my first choose this, not that. So for here, choose measures that you control, not the patient. So the measures that you see on the left-hand side are all screening measures, as well as the advanced care plan measure, which is a high priority measure. All 6 of those measures have decent, not great, decent benchmarks, the ability for you to also be the one that's in charge of it. So you're not dependent on a patient that has diabetes of it being well controlled. You're not dependent on a patient for high blood pressure and the ones that you see on the right-hand side. The ones on the left are questions not only that can be asked in a pretty simple form that you have, but also if the answers are no or they don't do certain things, you can answer it as you did the screening and you can either get credit or exemption for those measures. So you really have control. So I wanted to make sure that I put 6 measures together that you have control of, as well as it also qualifies being that the advanced care plan one has a high priority measures. The other reason that I have some of the ones on the right-hand side are because those measures are highly topped out. Many people do the documentation of current medications. I would say that's probably our most popular measure, if not in the top 5 over the last 10 years, probably the same measure. But the number of people that do that measure wrong increases every year. Make sure if you are doing documentation of current medications, you are including the dose, the frequency, and their route of administration. If they aren't there, you will not count. It will not count as a MET for this measure. So make sure, so a lot of these measures on the right side take a lot of documentation, and the documentation of current meds is also every single visit. It's not something that you can just do once. So what is a topped out measure? I mentioned this a couple minutes ago, but I did want to go over it a little bit more in detail. There are 2 different types of topped out measures. Those that are topped out at 10 points, basically what you need for that is you need to have a 100 to get the full 10 points. So you need to be perfect. And those that are capped at 7. So no matter how well you do, if you're at 100%, you're looking at 7 points. All right, the median performance score is 95% or higher. So those are so those 95% or higher, these are measures that everybody is really doing well on, and CMS is seeing not as much differentiation between each of the different groups. The performance is so high and unvarying that meaningful distinction, what I just said. And then after 3 years of being topped out, a measure may be removed in the 4th year. And that's what you're seeing with a number of these measures. They're being removed year after year. For measures that are extremely topped out, that means they're in the 98th to 100th percentile, CMS can remove those before the 4th year. There has been a couple of those scenarios where they introduce a new measure, everybody gets basically 100 on it, and they remove it because it's not really calculating anything that they need. So it's really important for you to be able to take a look at these measures and understand, what is your maximum that you can get out of them to score better. All right, so my next one goes into choose measures that aren't topped out. So these are more of choose this, not that. I tried to choose some different measures that were available within the program rather than the same that were on the previous slide. But you can see here on the left-hand side, these are measures that are not topped out that you can maximize your score for. Some that you can see here, like 226 and 431, they have decent benchmarks. They are just really hard to do because there is a lot of documentation for both of those measures, have multiple strata compared to other normal measures. I'm not talking about some of the more aggressive outcome measures that have a lot more documentation needed. So on the left-hand side, you can see immunizations for adolescents is actually something that is not a very difficult measure but your patients need to have gotten all the immunizations for you to count for that measure. The not this, these are all the ones that are really highly topped out and are popular measures. You can see measures like fall plans, elder maltreatment, heart failure, BMI, high risk medications, and once again, we have documentation of current medications are all really either highly topped out or topped out. You need a perfect score to even get 10 points on half of them. The other ones you need a perfect score will only get you 7. So it's really not doing what you need. So major point is for you to really understand what these measures are and where you need to go. Another trick of the trade that I've shared before is choosing measures that have small denominators. That's important here because what you can see, broad measures like the smoking, alcohol, medications have large denominators. Your patient populations, for these measures are 18 and above or 12 and above. Some of them are all patients. They also have no CP or ICD-10 codes that would eliminate or add patients to it. So you're looking at really high measures where even the ability for performance improvement's hard because to catch up on any negative it takes a lot more. So you only need to have 20 eligible patients, whether you're reporting as a group or as an individual. So you could have, if you're an individual, you need to have 20 patients, but if you're going to report as a group, the whole group only needs 20 patients that are eligible for this visit. Smaller denominators make it easy to control the outcome and are normally specially specific a little bit more to reduce the burden of asking questions like the vaccine status and so forth that maybe as your specialty you're caring for. So once again, I'm comparing the documentation of current medications, all patients 18 and over, each denominator eligible visit, no diagnosis code associated with it. Compared to a measure like measure 39, screening for osteoporosis for women 65 to 85 years of age, we have a females, so we're cutting our population basically in half. 65 to 85, you're cutting your population again. It's only done once per performance period, and the patient needs to be not diagnosed for osteoporosis on the date of the encounter. So what I did on the next screen is that I broke that down into what it looks like and the total number of measure instances that you need to calculate. So on the left-hand side, so what we're going to take for both of these is that this is a 2 clinician practice, 5,000 patients seen over 18 years of old. So we're just looking at those patients. Each one has been seen twice in this scenario for 10,000 patient visits. Half the population is female. 40% of the female population is between the age range that we're looking at, and 70% of the female population doesn't have osteoporosis. These are purely fictional, made-up numbers to share with you. So what you can see on the one side, documentation of current medications, all you're working with is the total patient visits is 10,000. So therefore, you need to do 10,000 qualifications for the measure. Now there are some exemptions, so it might be little tiny bits here and there, but for the most part, you're looking at needing to do 10,000 total. However, on the right-hand side for the measure that we talked about before, screening for osteoporosis, you're looking at the total patient visits of 10,000 once per performance period. So now we're cutting that number in half. So those patients were coming in twice. Now they're only coming in. Now we only have to count it one of the two times. It's an important caveat here too. A lot of measures actually have the ability for you to play catch up. So if you don't get the answer in the first time, the first instant that the patient comes in, you have the opportunity in the second time to make that happen. Utilizing reports like our gaps in care report here within MIPS Pro, you can see what patients don't have the answer in your first quarter, your first month, whatever it may be, and then make sure that those patients are identified in your EHR to get it. We're eliminating the male patients, which is about half of the population. So now we're down to 2,500 total instances. Patients not aged 65 to 85, right? We worked on 40%. So now there's only 1,000 patients that are eligible for this measure. Now we're going to take out the 700 patients that have don't have or that have a diagnosis. Have a diagnosis of don't have a diagnosis of osteoporosis, which leaves us with 300 in the total measure instances. So you can see for a measure like this, 300 on the one side and 10,000 on the other. 300 is a lot easier to catch up on. 300 is, you're looking at that, it is a screening measure, so you're asking questions. You're not dependent upon the patient providing you information. Like a lot of times, if you don't have certain EMR systems, you need to be dependent on provide a patient coming in with a long list of their medications and the dose and the frequency and everything like that. It did have, while I'm here and still on documentation of current medications, I did have a question that came up is, when did the documentation of meds currently change to include route, dosage, frequency, etc.? It is 100% been required since the beginning of MIPS. If you're not collecting that data and you are audited, you could have to return your incentive or be penalized. So that information is 100% been part of MIPS since the beginning of MIPS. I would have to check if it was around in the PQRS days, but I am pretty positive it was then as well. That's 6-7 years ago now at this point. So that has actually been part of what's been needed for those measures. It's in the rule of the measure for each one of those. So choosing new measures is really something that I am pushing people to do this year. Here are the new measures that are in the CQM category for this year. You'll see a lot of these may be specialty driven, but there are two measures that I want to point out that I believe most providers and practitioners, clinicians can answer or do as part of their routine with their patients. And that's measure number 487, which is screening for social drivers of health. And then the other one is adult immunization status 493. Those, the adult immunization status one, that includes the pneumonia and the flu vaccine, as well as other categories on top of that. So the benefits of reporting a new measure is the first year measures minimum of 7 points, whether the measure was scored against a benchmark or not. And then the second year measure, it is 5 points, whether the measure is scored against or not. against a benchmark or not. So what I'm trying to get at here is that first year measures have a minimum of 7 points. No matter what you do with that measure, you have 7 points is the lowest that you can get. If you're seeing measures that have a maximum of 7 points that you are doing, know that you could just do a new measure, not even perform very well in that measure. Their performance is not there. The minimum is 7 points. Highly recommend that you add a new measure this year, even if it's your 7th or 8th measure or 9th measure that you're tracking. Add a new measure so that at the end of the year, or when you enter this information and send it to CMS, you will have a measure where the minimum score is going to be 7. And it may be worthwhile to have that in there, especially if there's other older measures that you're reporting that don't currently have benchmarks and you don't know accurately what you'll be receiving for those measures. So highly recommend picking a new measure for everybody I talk to, no matter how well you think you're going to do in MIPS. I'm finding it very, very important to pick a new measure. And that will continue the same as long as they keep the 7-point structure. You should do that every year. I do want to add to this too, the first year measure for the social drivers measure, I think on the previous screen. So it's measure 487s for screening for social drivers of health. That is becoming more and more important. I think I stated in an article I wrote a couple months back that it was written about 700 times in the final rule talking about social drivers of health. It is a very difficult measure as people aren't used to answering many of those questions, but for the most part, I believe that CMS may add it to a lot of the programs moving forward, whether making it mandatory or offering better opportunities to score well on that measure. Next on here, I'll go over the removed measures for you. So a couple of the removed measures are pretty significant, as you can see here. They've been measures for a long time, especially when you take a look at the lower numbers like the 76 and 119 have been measures since the PQRS days. Measure number 265, I came from dermatology and worked with a lot of dermatologists for the better part of the last decade. 265 was always a pretty mandatory one when it comes to working with dermatology, as well as I'm sure your urology and GI and so forth. Getting rid of that, they fought to keep it many years, but CMS finally decided to remove it in 2023. And as you can see down the bottom, those measures 110 and 111 were removed just from traditional MIPS. So if you're part of an MVP, they may still be available there. If you're part of an ACO and doing web interface, they are available there as well. But these are removed from traditional MIPS, which most of the people on this call are participating in. And you are taking a look at that they've been added in to that measure on the previous page for adult immunizations, along with 2 other immunizations. It is a little bit more difficult of a measure, but something that I suspect will be a popular measure moving forward. So what do you do for measure improvement? Go over a couple things here as we're doing this. Monitor your performance on a regular basis. So when I was consulting for people in the MIPS area, I always tried to interact with them on a bi-weekly basis to make sure that they are seeing where they are, making sure that there's no dips. There are things to look out for. New hires is something that tends to sometimes get things to change direction, whether the new hire is doing a better job than the staff that doesn't want to do MIPS anymore, or the new hire doesn't understand what needs to be answered for each one of these questions. So for this is really checking on a weekly or bi-weekly basis. I know some of the people on this call are obsessive about it, like I would be, where you're checking it all the time. However, I do think that to be able to see trends, you need to spread it out a little bit further and check on a weekly, bi-weekly basis. Be able to see where your measures are, where you stand currently, what changes you need to implement. CMS does change some of the rules throughout the year. Always great moving the goalposts while you're trying to go after it. So staying in contact with Healthmonics and our blogs and our webinars can help you with what you do. Being able to really understand not only what your quality scores are, but that you've completed the best you can for both PI, IA, and you're doing the right things when it comes to cost. So in our system, we easily have the ability to break this data down on individual measures or even down to the provider basis. Understanding and identifying driving performance improvements into your gaps. So here, this is within the MIPS Pro platform. You can choose your measure and the status, as well as your individual provider or location. Those are added features in 2023, and have the ability to filter that out, see what patients aren't met. If you want to export this to Excel, or if you want to work with a certain person within the practice to understand what's missing, why is it missing, and is this data that we can catch up on or figure out, you could do that right within this program, and then go in and either update it in your EHR, or if you are manually uploading or manually putting data into MIPS Pro. I think it's really important to understand what can drive your performance improvement. There are measures that have very wide benchmarks where, getting 10 more patients doesn't make sense, or even 100 more patients to a yes doesn't change your score drastically, maybe a quarter of a point or something like that. But there are measures where, lower denominator measures where the benchmarks are a little closer to each other, and you're currently at 6 or 7 points. And if you answer, or if you're able to bring in patients or work with patients to get yourself up to 9 or 10 points, you may have the ability to do. And the way to do that is through a program that allows you to track your gaps in care. Working with underperforming providers and staff, you can see here this list of providers has a very low numerator and denominators, as it's comes from my test site, excuse me, as it comes from just my tests and what I'm doing. And what you see here are what it looks like from a perspective of met and not met on this list. So you could work with individual providers and staff to make sure you are where you need to be. A lot of times when you're seeing this, you'll be able to tell that there are certain groups that are keeping your score down. And maybe it's only for one measure, or maybe it's across the board, and we need to figure out how they're impacting your overall score and what you could do about it. Category eligibility. All right. Before I get there, I did have a couple questions that came up on here that I'd like to at least share while I'm going through it. Small oncology or specialty group, how do we know if we have cost measures? You could talk to someone here at Healthmonics and we'll give you that idea. Oncology definitely has specialty measures for cost. You need to meet the case minimums for you to qualify for them, and that's as a group. So I can share with that information if you have questions on that. The other question comes from, do you have suggestions on measures for our individual specialties? On our website, you can see there are the CMS specialty measures, but within the MIPS program, one thing you'll be able to do is take a look at what your specialty is and what billing codes you put out there, so that you can figure out exactly what measures. I also do recommend we have consulting partners that can help you with measure selection and things like that could benefit you moving forward, to be able to really understand what measures you need to select and which ones have the best point options. So another question actually about the new measures. Do we need data completeness in order to get the minimum of 7 points? Yes, you need to have data completeness, meaning that you need to report denominator data for 70% or more of your patients. Doesn't mean that you need to have more, it doesn't mean that you need to have 70% met, just 70% data completeness. So met, not met are both counted towards that 70%. So it doesn't necessarily mean your numerator and denominator needs to be 70 over 100. It could be 15 over 100, as long as you are reporting on 70% of your overall data. Here's another one. Do members of small groups who choose to submit as individuals get the same reweighting and bonus points? As long as they're part of smaller groups, small individuals do get that. If they're part of a large group and doing individual reporting, they are still scored from a large group. So it really just has to do with what your group size is, not the individual status. All right, I'm going to go through a couple more, and then the questions are still coming in. These are great questions. Thanks, everybody. But I want to make sure I'm able to get through these slides. Know what categories you need to report on. Do you need to report promoting interoperability? As I said, small practices, 15 or fewer eligible clinicians are automatically exempt. Clinicians such as nurse practitioners, therapists, psychologists, non-patient facing, providers are automatically exempt, and some providers can apply for an exemption. So decertified EHRs, extreme and uncontrollable circumstances, and so forth. Promoting interoperability is only 90 days, so all certified EHRs need to have the capability to track the measures. You may be very familiar with these measures, so maybe it's worthwhile to take a look at, and you can opt in to report promoting interoperability. So if you're going to score a perfect score in PI, I highly recommend just continuing to report it so that you can get the maximum points. So for a group here, what we're taking a look at, and this is a large group without PI, you can see what the quality score, I'm sorry, this is for a small group. So without PI, what you have here is a quality score of 28 over 40. You have a perfect IA score, as well as I gave each group 50% on their cost score because we don't know what that is right now. And on the left-hand side, so without PI, you got 73 points, which is not avoiding the penalty. So if you were to report on the right-hand side and the same percentage for quality, 21 of 30 instead of 28 over 40, perfect score in IA, half the points for costs, and almost a perfect score in PI, you get to the penalty avoidance threshold. So it isn't necessarily 100% mathematical accurate to say when your score for PI is better than your score for quality, but it is pretty close, and I would pay attention to that. If your PI score has the ability to up your score, continue to do it. If it does not, then you can not do it, especially as a small group, and it's not counted against you. Just more information will be pushed towards the other categories. Know what categories you need to report on costs. So there are a couple cost questions that have come in. Any specialties that typically are not scored on the cost category was a question that we have, and I'll get to that in a minute. I believe on the next screen I'll have that. So for instance, will you be eligible for the cost category? There are minimum thresholds for each of the measures. The two main or oldest measures now at this point, they're not main because every measure is counted equally, no matter how many patients or episodes fit into that measure. But what you have here is the TPCC is 20 patients, which is the total per capita cost. MSPB, which is the Medicare spending per beneficiary, is 35. And then each of the episode-based measures have 10 to 20 patients that are eligible. Important part to remember is that this is group information. So it's your entire group that counts for each of these measures. So even as an individual, if you had 5 patients per TPCC, but you have 5 different partners in your group that each had 5, now you're going to be above the limit for all of you, even if you report as an individual. There is no reporting If you don't qualify for any of the measures, you'll automatically be excluded. Very important to remember, excluded, not exempt. Nobody is officially exempt from costs like you would for PI. You just wouldn't have the denominator eligible visits, which makes it excluded. You get that reweighted based upon the patient population that you have. So here are here are the provider types that are attributed the total per capita costs. So it has been updated since you last paid attention to it. So back in 2019, there was a different list that included basically anybody with a plurality of visits would be given the TPCC category. So you can see here there are a number of group types that are included, but it is important that there are many specialties in here, as well as nurse practitioners and physician's assistants who are also counted for the cost category for the TPCC. For the episode-based measures, so everything from the MSPB to the other episode measures that are available, these are the main culprits, the main provider types that are included in each one of these measures. So you have really the understanding that this is not a total picture. If you have patients that fall in the eligibilities, you may have be given a cost score. So the best things that you can do are to take a look at your old information through CMS to understand where you may be calculated, and or work with a company like Healthmonics that can provide you with estimated cost scores, looking at your previous data throughout the entire year. So some overall MIPS strategies. Get the right systems and people in place, the workflow steps that help you win. Conduct a workflow analysis to identify areas of inefficiency and opportunities for improvement in your MIPS practice, MIPS reporting process. That's number one. When I was consulting, I would walk into a practice and understand, okay, where are your strengths and weaknesses? Do you have an EHR? Are you working with some type of practice management system that can answer some of these questions? Do you have the staff that can take care of these things before it gets back into the clinician, where time and money is of essence when you're dealing with, the cost of that expensive part of the program? Look for areas where data collection, documentation, or reporting could be streamlined or automated. Could you use a system? There are a lot of programs out there that do intake now, that do pre-calling of your patients to answer certain questions prior to their visits. There aren't only internal opportunities. You do have programs that are out there externally that can help you streamline and automate some of this business. Use technology such as EHRs, your practice management systems, as well as other reporting softwares like MIPS Pro to streamline data collection and reporting. You want to make sure that you have the right ones in place. EHRs are hard to change from, I understand that, but there are some really good EHRs, some of our partners here at Healthmonics, that we believe are really doing all that needs to be done to reduce burden on our clinicians, as well as maximize not only the quality of care, but your quality scoring within this program. Monitor your practice performance data on selected measures and categories throughout the entire year. Make sure that you are tracking it all year round. Use this data to identify areas for improvement and adjust workflows as needed. Don't just give up on the year. Look at it after Q1, look after Q2, see what type of changes that you can make and where you can go to be better. The workflows that help you win. So these are going to be each of the things that I just went over in a little more detail, but conducting your workflow analysis we talked about. Look for areas where data collection and documentation could be streamlined. So whether it is taking something like an intake form, like you see on the left-hand side here, and you have the patients and information, as well as you make sure that they have the dosage, frequency, and route for the medication list, what the answers are for each one of these. You don't need to say that they're MIPS answers, right? So you don't necessarily need to say this surrogate decision maker is for measure 47 for advanced care plan. That is internal. Externally, you're just asking for who the surrogate decision maker, what the relationship, any other questions that you want to add to that category. You can do that as well, and have everything there. Putting spreadsheets together like you see on the right-hand side that includes the patient information all the way through the answer codes for each one of the reporting. How does that workflow? Where can you fit that in? Can you get that type of documentation out of your EHR? Can you get it from your billing company? Some things like that to get the right systems in place. Know your technologies. Use technologies such as EHRs and practice management software and so forth. This is just a couple of our partners that we have out there, but MIPS ready to stream your data collection and reporting options. Monitor your practice. Ability to take a look at the practice, what's going on in your patient practice performance data for the year. Look at where you stand for each one of your measures on a regular basis. And then use this data to identify areas for improvement and adjust workflows. Where are you doing poorly? What type of patient population are you not getting the correct answers from? What providers, what staff aren't you working with to make sure that you are maximizing your performance? Talked about this before, reporting as a group and as an individual. This is my last real slide before I have other things. I know I'm quite close to the timeline, so if you have questions, get them in now. But report as a group and individual at the same time. The example below is a 20 provider group. If you are reporting as an individual, some providers will be above that average and some will be below. The patient minimum for some of the measures is harder, and you can't take advantage of patients that see multiple providers. Group scoring, everyone gets the same score. Everybody gets the same exact score. Some providers get pulled down by lower scores, and sometimes it can cause some internal turmoil as you are not pulling, some providers are not pulling their weight. But if you report both, those providers that got higher than 89 are going to get their individual score. Those providers that are lower than 89 are actually going to get the group score. So it's the best of both worlds. And then the practices take advantage of a 20 patient minimum, especially providers within the group and top performers. So that's really it for the presentation. I will share how MIPS Pro can help you. Our best-in-class US-based support and integration teams are here to help you reduce the burden, have the ability to really maximize your score, not only this year where we're really looking to push people to the highest scores, but even to avoid the penalty, we're here to help. Stay tuned. We have multiple webinars coming up in May. And feel free to reach out to me at the information below. Those are my direct line as well as my direct information. The last question I did have on here that I want to get to is any specialties that typically not, oh, we did that one before. The EMA process question came up. Do you have info on the EMA for the specialists? I'll check with my team. I don't know if that has been released for 2023 yet, but I will work on that. I believe I've got to most of your questions. I am close on time here too. So if you have anything further, please feel free to reach out to me. Otherwise, thank you very much and have a wonderful afternoon. Appreciate it.